So I am going to close the computer and bring some chairs up here. I'm going to ask the experts. We're going to make this table work and put 4 chairs up here. And so give you guys an opportunity to ask them questions. If not, they'll feel the wrath of my questions. So please ask questions. Make it easy for them. Give them the opportunity to clarify anything on their behalf. One more. I'll grab it. Dr. Brahmi, would you like to? I'm going to pull you at the end. I'm sorry. Yes. Are there any questions? Oh, perfect. Thank you, guys. Make my life easy. I'll start with Erica, go to Desmond, and then.
Okay.
Yes.
Thank you. Thank you. Well, I have 2 different questions, and maybe will sound a little bit stupid, but I have that. I am curious about that. One is we talk about this disease, and it's an inflammatory disease, right? Is something additionally that can help us, because now you hear a lot about the food anti-inflammatory diets or vitamin. I mean, is something on the food or vitamins that can help us to reduce inflammation?
No. Here you go.
So in the past, it was called synovitis, which is an inflammatory disease. But this one, as Brahmi also underscored, is a tumor with a specific pathogenic driven signal. Of course, there is this loop in between tumor and inflammatory changes. So it is true that there are both components, but as long as you don't interrupt the loop, I think it's unlikely that the inflammatory changes goes away. Although some edema is, of course, might be transient and also related to the physical activity and so on. So probably in the active surveillance, some change can be also driven to the inflammatory reduction, but I'm not sure about the diet though. Do you have any idea?
I totally agree with you. So, of course, is an inflammatory disease, and as you see in the study with active surveillance, 21% of patients improve the symptoms within the active surveillance, and maybe that you can improve symptoms only use chronic analgesics for the disease. But I think that the message is that the disease cannot be controlled with analgesics drugs, but can help patients to better control the symptoms, especially when we propose active surveillance. This is my opinion.
Yeah, we like a holistic approach, right? With treatment, complementary, not instead of, no substitutions. Yes.
So we know that the pathology report is the gold standard to decipher between localized and diffused. Do you think biochemical diagnostic tests could be a better way to, like a blood draw, be a better way of trying to than a biopsy? Would that be a good solution?
It's almost like 2 mics would be helpful. Go ahead.
So we prefer to use nodular and diffuse type. And so I think no, we don't have data on this. And today the better approach for diagnosis of TGCT are the radiological assessment, MRI first, then clinical, the symptoms and clinical situations, and of course, as we state in the consensus document, biopsy is recommended to the pathological diagnosis, but we don't have a biological biomarker in peripheral blood or something or similar to for the diagnosis. And as the surgeon already said, we can avoid the biopsy only in referral center when the radiological images and clinical are consistent.
but it's always the exception of the case. I in a referral center like mine, I would never forget a case of a girl, 35-year-old from Sardinia, below the knee, very nodular lump, dark in T1, super. I mean, I could put my hand on the fire that it was a nodular TGCT. And then Professor Donati saw it with me, and he was like, "Oh, TGCT for sure." But then he planned a biopsy head, and it turned out a lump of synovial sarcoma. So in medicine, 1+1 is never 2, and and even if referral center, you can make mistakes. So I think that I really, as an oncologist, love biopsies.
And just to add that on this, um, if you have a diagnosis of TGCT in a peripheral center, is always recommended a second pathological revision, often, especially when the radiological assessment is not coherent with the clinic. And this is another important point that I would like to stress.
And also, I would like to add that if we decide for you a prescription of a treatment, TKI, monoclonal antibody, you have to keep in mind that those drugs could have side effects, and those side effects could be sometimes severe. So it is mandatory to have a diagnosis of 100% of certainty to prescribe those kind of drugs. You cannot prescribe those kind of drugs without being sure that your patient has this disease, and to be sure, you will have to make a biopsy and to have a pathological report, and of course also a second opinion for the pathological report.
So can I steal it and ask a question then, a clarifying question? So Desmond asked an amazing question of that the biopsy results would tell you whether it's diffuse or nodular localized, whatever the term is. And we don't know that from the consensus. That's not the case, right? We rely on radiology reports. So is there a reason perhaps why someone would have a localized disease or a diffuse disease, but the pathology report would say one or the other, right?
The diagnosis can only be done by the radiology, because the pathologist sees only what means a biopsy, because the biopsy is relatively easy done, because mainly you have a really big tumor mass in the knee joint, and it's we do it by local anesthesia, but you can discuss it. We make a small incision, and then you have enough tissue. Sometimes if you have the tumor mainly located dorsally, it might be a little bit more difficult, but normally the biopsy is really easy. And the distinction between diffuse and non-diffuse cannot make the pathologist. It's MRI. And sometimes, even not the MRI, sometimes the diffuse type is seen only by arthroscopy, that you think it's a nodular, but the arthroscope surgeon says, oh, there were some small nodules, brown nodules in the synovia. So finally, this distinction can be made by surgery, if we have to be honest, but mainly by MRI.
Yeah, I agree. The WHO describes some specific feature of one or the other, but being medicine never 1+1, you need to combine radiology with pathology. No pathology would write nodular or diffuse in the report without looking at MRI. But yeah, it's quite standard in diseases of the soft tissue of the bone to always combine pathology with observation of the radiology, so it stays in that spectrum of diagnosis.
And also, if you have a nodular TGCT that relapse after surgery, you have to go back to the record of the patient, because it might have been from the beginning a diffuse, but we've missed the diagnosis. Yes.
Thank you so much. I'm going to selfishly use that when someone asks me, why does my report say diffuse on it when it's localized? So thank you guys. Another question. Yes, I'm him first and then yes.
More looking at the recovery side. So maybe for your patients that have had one at the back of the knee and nodular one, some people say that, maximize the physical activity after the surgery as much as possible. Some say just really take it easy over the first, whatever, 6 weeks. What is your experience with your patients? What has worked? What has not?
Thank goodness we have a surgeon to ask. Please.
1 + 1 is not 2. I'm more conservative because I think that first of all you can ask, would you make, this was not asked, if you have a diffuse type tumor and you decide for surgery, make you 1 stage or 2 stage. And there Van den Sande et al. Did some papers. I think Bologna was included. The question is 1 stage. This means you make both surgeries in 1 surgery, or you make it 2 stage. I think Mikhail showed no real no real difference. Clinically, I prefer to make it 2 stage because more problems are from the dorsal one. More problems are from the dorsal ones. And again, if I see patients treated elsewhere where we have then sometimes vessel complications, sometimes nerve complications, a stiff knee, etc. So we normally start with the ventral part more or less arthroscopically. We discussed about the open arthroscopically, and then we decide to make the dorsal one if the patient has complaints. If he has no complaints, we wait. So this is the first thing. We make more or less 2 stage, but you can make it in 1 surgery also, of course.
Just back.
Yeah. So I would say you can do it as the surgeon says. You have a S. We do it like this. Not always an S-shaped incision. If it's big, sometimes you have a straight one. If it's not so big, it depends on the size. If I would have an S-shaped entrance, I would be a little bit more calm because this is from sarcoma surgery also. You will recover. First look that the wound is good, that you have a good scar, etc. Because there I do not actually know how often we have wound complications or secondary problems with the scar in the dorsal part. So I would say some weeks of a little bit rest, of course, movement, range of motion improvement, but not do everything and then it will be fine. I'm a little bit more restrictive, but this is not evidence-based. Of course, physical therapy, and also think about lymphedema. Again, this is sometimes more difficult, like a sarcoma resection, because we destroy in these surgeries also lymph vessels. We should never forget. You cannot discriminate between. I would make physiotherapy, lymphedema things, and so on. Yes, but sometimes a little bit less is better than to go too straightforward.
So I have a question. If are there any online consultation with expert in this disease available for the patient from different different countries, just to confirm the even if it's a diffuse type of the localized type, just expert consultation, yeah, even paid, of course. It's
So tumor boards, huh? So do you guys want to take, we do tumor boards where that happens.
So we in my institute in the past we had a remote consultation, means there was a technical room where all the images were uploaded, and then an online consultation at the end of this process. But then they decided that it was not convenient. I don't know why, also during the COVID. So not in my center.
Same for me. Yeah.
So what we do often is if your doctor is willing, we'll set up a tumor board. And so your doctor would present, and some of these lovely experts would be invited to give comment. We would write up what happened in that tumor board, and we would give it to you and your doctor to discuss. So that is a way around some of these institutional problems, and that's an option. Dr. Bauer also does see patients outside of the country and through consultation all the time. So it is an option depending on the site.
Yeah, we received several emails with questions from the patients. I always invite them either for in-person visit, or I'm available for their oncologist, because it's more easy for us to be also from a medical legal standpoints, to be in contact with other oncologists rather than to take a decision in remotely.
Yeah, I think the same.
Yes.
Is it true that habitual shoulder prolapse is a common symptom with TGCT?
Frozen shoulder of unrelated limb. So unrelated. She has hip. So
Again, what do you mean? No, 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 no. This is not. This separated. This separated. The same question is, how often is this disease in two joints?
Oh, that's so sad.
This is all could be a question. In my opinion, it's a never or never, never. This could be the question regarding a relation.
I saw multi join. Oh, very anecdotal, but it can happen.
Likely that you have this disease in the hip and in the shoulder if you ask this.
But the question was not this. She asked is
If
maybe
the collapse of the
yeah, so it's not a systemic disease, right? It's a localized aggressive disease. So it'll only impact a single joint, except with anecdotal. So anything that's unrelated or outside is probably not related. Yes.
limited range of motion. Pain.
But unrelated then. Yes. Yes.
That's probably related. Also, I'm from Prague, struggling with this disease for some time. 5 surgeries, diffuse and ankle, and also like I have pain in my hip, in my knee as well, and always asking me myself if I need some scan for this or that. I mean, didn't do it, but yeah. So it's not as you say when it doesn't move from the hip to the shoulder. So it's probably not even moving down in the down part of the body.
People compensate too. Like you have a lot of compensation in your body.
Yes, it's exactly that. You have to be careful when you have this kind of disease, I mean in the right knee, because it will have an impact on all your body. And sometimes, yes, you will have pain in the other knee or elsewhere, and you will have likely sooner problems such as arthrosis or things like that in the other joints. So it doesn't mean that it's going to the other joints, but it is the secondary impact of the disease.
Or from the orthopedic point of view, I have not so rarely patients. They come from another or from not so experienced centers, and they say, suspicion of 3 joints of this tumor. And then you know, if you have a big synovitis, that this is rheumatism. That cannot be. This is not the case. This is not so rare that the radiologists, outside radiologists, do not know it. So then it's normally a rheumatism, etc.
You'd be surprised the amount of patients we interact with that say that so it's more common that they're misdiagnosed one.
I would like to know, are there any discussions or ideas or thoughts in order to avoid recurrence
after operation of diffuse form TGCT, because we heard like multiple operations some patients have, and then it recurred in scar tissue formation, and it gives a lot of complications. So would it be an idea to combination of operation plus systemic treatment? Are there any actual discussions ongoing to know?
Yeah, can these drugs be used prophylactically, preventatively is a good way. I'm gonna just throw it at you guys.
This is a very, very, very good question, and thank you for this question. I will let my colleague answer also, but I don't have the answer. We should maybe ask this question, but as of today, we don't have data in the literature that could help us deciding on adjuvant treatment. But maybe we could think of adding systemic treatment before or after of both for diffuse type. Yes, maybe it could help preventing the relapse, but I don't know, in fact.
When they recur,
Of course.
so that's let me.
I think the same. We do not have data about this. I think that some patients in clinical trial with pexidartinib were operated after the treatment. So it's a very interesting question, and I think that we can explore this on the future. No, and in that patient with a local disease, very extensive disease, local, and then we can start with the medical therapy to shrink the disease, and then have a better surgical operation, I think, no?
Yeah, we in my orthopedic surgeon proposed several times, and also my Michael van de Sante, we discussed about neoadjuvant study, but we weren't able to convince any clinical pharmaceutical company to do this very selected population on clinical trial. While adjuvant would be really, really not happening, I think, because it's a benign tumor again. So with even after surgery, there is no possibility to even check on the response or activity. So it's very difficult to propose such a study in a benign disease. But neoadjuvant, I agree.
And I also want to say that we will have good evidence for this from phase 4 clinical trials, because when we will have drugs in our clinic, we can do this.
What you also find is just because you have disease does not mean you have to treat it. So the side effects may be worse than actually leaving the disease if it comes back. So we have to, that's the balance, right? That all of them deal with and I just get to talk about. So.
So the question was, does it spread to another joint? And it doesn't, obviously. But through surgery, for me, it wasn't encapsulated anymore, so it grew towards the calf. So is there a way or a higher risk that if it's not encapsulated anymore, that it spreads somewhere?
There you have the best situation. And even there, it can go in the muscle. After the first surgery, you have no joint capsule anymore. And then it can be, as I said, a combination of intraarticular and extraarticular, because you have no joint space anymore if you do a ventrodorsal resection. This is not the normal anatomical situation. And then, of course, it can invade muscles or something else. Yes, then it's really difficult to get the margin. This was the question, that we can clearly see surgically the margin. This is not possible.
If the question is that if the disease can give metastasis, the answer is yes, very super rarely, where anecdotal cases of lung mets were described. We had a couple of cases with lymphnodal metastasis, and the pathology, they did an amputation because the knee was all really impossible to be used, and the pathological confirmation of the benign nature also of the lymphnodal node. So it is possible, but it happens very, very, very rarely.
So rare it's not described very often at all in literature, right? Can I hijack and ask a question then? So I get asked all the time from patients, does a localized or nodular disease, can it become diffuse disease? And my answer is always if surgeon error, minces it up. But would you agree those kind of questions?
I would agree. I would say if an arthroscopic surgeon would shaving means destroying the tumor, and then you have a complete seeding of the tumor in the joint, and then you can convert iatrogenic nodular form to a diffuse form. This is a physician mistake. Otherwise, I would not say.
I agree. I don't have any experience this progression from localized, but it's also, it's a very well taken. I mean, it's possible that seeding causes extra-articular growth back. That it's impossible to distinguish from a diffuse type per se from the beginning.
And Sophie.
Just quick. Yeah. No, it's just quick. When my diagnosis was first given with the wrist tenosynovial giant cell tumor, I was only getting MRIs of the wrist. And then after a couple of months that they noticed in the other wrist, that was something going on. So the doctor said, let's do the both wrists. So now I get the both wrists done. This is always the tenosynovial giant cell tumor. And now this is mild synovitis, and it's not designated. So will it remain that, do you think? Because I'm hearing that the doctor even said, not bilateral. Usually they're not bilateral. So mild synovitis, that wouldn't then turn into the tenosynovial. No. Okay. All right. I just need that confirmation.
Yes.
Observable bilateral TGCT in super rare cases.
I will say like half of the experts we had during the session has never seen anything similar. So it seems very anecdotal one-offs, not to be concerned, I guess is a good way to put it. Yes. Not one more thing.
Sorry, I was just wondering if we could educate orthopedic surgeons on this. I don't know if they have a conference every year or if there's any.
Is there a list like oncologist, orthopedic oncologist already educated, but I think patient representative Jessica Sidney makes.
Yeah.
And it's still already happening because any patient to social network can be in touch with Sydney, and then they will go way around from orthopedic oncology, from orthopedic to orthopedic oncologist to oncologist. So I think it is really very educational.
We are trying that.
Yeah. Well, I think this. I don't know if it's a problem globally, but definitely in the UK, I've had a problem with going locally to my local hospital, and they don't have orthopedic oncologists. They just have orthopedic surgeons who wanted to take it out straight away. He said, "I've seen this before. I know what I'm doing." And luckily, I got in touch with Sydney. And got referred down to London to a specialist orthopedic oncologist. And after reading the consensus paper, I think that was a really good thing to do. I think you need to have a multidisciplinary team with radiologists involved. I think orthopedic surgeons need, especially orthopedic surgeons need to be educated on the medicinal options as well.
Organizing a clinical trial launch within the same combined Platea. Now, after 9 years, I have referrals from both, and I think that this educational work pay off because it's always a very debilitating diseases and also unsatisfying for the orthopedic surgeon itself, because I mean, having a patient with a coming back and some morbidity is not pleasant, so it takes a little bit of time, but will eventually happen.
The question is very good. The problem is how often we have synovial proliferations which are not this tumor entity first, and the second is you told we have no second opinion or it's difficult, but you said then I have each day mails from colleagues or even patients, and I think patients and also colleagues, I think we all do second opinions. I would say I have each day 10 to 15 mails from Germany, not of this tumor, but in my field of tumor orthopedic surgery. 10 to 15. And you need a good availability for colleagues that they know I can mail Hades, and Hades mails back to me and says I should send the patient or send me the picture, etc., etc. The problem is, as perhaps only in Germany, there is no reimbursement. You understand? The problem is that we do all. I think I can speak for all of us. We do a lot of clinical work, and for this reference things, you have, at least in Germany, no reimbursement. But we do it. I do it. I answer each mail. But you need the orthopedic surgeons have to know. Oh, I can mail Hades, and Hades looks to the patient or to the picture, at least to the picture, and then you say what to do or refer it. And I think this is really difficult. Educational, it's difficult. We have in Germany 10,000 orthopedic surgeons, 10,000. And a lot of are in private practice. They do not visit a congress anymore. They are in private practice. They do not come. How will you reach them? This is really difficult. So you can only try to make it open for them, but you cannot force them to do it.
That is our major issue. I sent, and some of the people here, 720 emails to orthopedic surgeons, and we got 9 responses. Why is that? They use Gmails. They don't have institutional emails. They're private small centers. Reaching them is incredibly difficult. And I'm going to put the onus on some of the pharmaceutical people in here that money can help in the situation, that putting a question on an intake exam would require them upon getting their license to know something about it. And that is a money thing, right? So just thinking about things we can collaborate on.
When you talk about education, I think that education of radiology is very important.
Pathologist.
Very well. And then the orthopedic would maybe think of addressing the patient for a second opinion in an expert center. And every physician, every specialty should have this education, not only a surgeon, but also the other physician that might see this disease.
And using the same name. The fact that we still say the word pigmented villonodular synovitis makes me cringe. Right? Same word, right? One and then, yes.
Duly noted, Sydney. I have a question with regards to the discussion about active surveillance for diffuse TGCT that's asymptomatic and not progressing. How common is that? Do you have those types of patients where it's just active surveillance? And then my second question to that is, how often then are you monitoring to see if they've progressed?
And there is a paper, if you need it, directly about how many patients.
Yeah, in that paper just published last year on 59 patients, about 60% were non-progressing after active surveillance. So, oh, the picture. Quanti, sì. No. You ask how many patients were. Yeah. Yeah, I think I say about 60% in that paper.
Just for a tidbit from our registry, people who were diagnosed, majority of patients globally, and you'll hear I'll give a talk about it, but 50% non-US patients, 50% US patients, regardless of where you lived, majority of patients upon diagnosis were treated within 3 months. Too fast, right? Like immediately. So active surveillance, slowing down, those kind of things are important.
First, we are talking about radiology, education of radiology. In the case of Andy, radiology, it's ha capito. I understood that it's a tumor, okay? And also, they told me, the doctors told me that PVNS, it's not TGCT, okay? It's not the same thing. And in that way, I have to inform about the disease, okay? But the liquid that extract him 3 doctors, okay, 3 times, okay? No one can understand that it's TDCT, just radiology. Okay.
Yeah, you'll find that it's common. I get so many, like, is this the same disease? Is PVNS the same? And you're like, yes, this means get a different doctor. Different when peds, right? You're limited in how many doctors, but
Just to tell you a quick case from Lyon to illustrate that this is a real issue and a real problem, these 2 names. I had a colleague that called me for a patient who had a TGCT. So he treated the patient with denosumab. And he called me and tell me, I don't know why, but usually denosumab works very well in TGC, and for this patient it doesn't work at all. So what are you thinking? Can I have a second opinion from you? And so I explained to him that it wasn't TGC of the bone, but TGCT. So it's a real issue, and it was a colleague that is a medical oncologist.
I had the same experience, so it's very important to be again in a referral center. Never mind.
waited so long. So right, it has. Yes, we're working.
Yeah, this nomenclature, it's driving us crazy.
It's
All
tricky.
of us, yes.
Yes, when we are talking about these common mistakes, let's say, no, hope not so common. Is there any statistical significance with some other autoimmune disease or oncology disease with this TGCT or anything that might be important for patients?
No, yeah.
I just know that we are referred only the TGCT, but outside there are, I mean, I think we see the iceberg spike of all these inflammatory changes, and I think it's. I mean, it's before biopsy. It might be very tricky.
Leiden once said that 1 in 10 of their patients that comes from outside centers with TGCT actually have gout. So they're misdiagnosed entirely with gout. So, but no, there's no risk factors associated with autoimmune. You're not more likely to get anything else just because you have this disease or vice versa. Well, if there are no more, one more question, and then we will say thank you to all of these lovely people. Oh, okay. Okay, where can we look to join medical trials? Great question. So for all of these people, it depends the country, I will say. But depending on the country, there's also clinicaltrials.gov, which is a US based, but it does have pretty much every trial in TGCT is registered with the US, so you can see all global sites. I don't know if you guys also.
I think either ask Sydney. No, but yeah, there is a clinical trial that gov that it's very handy, and of course, speaking with an oncologist, I mean, at least I think it's on our duties to provide that information, especially with a disease that has no approved drugs in Europe. We should be able to refer patient to clinical trial, which is paramount to get insight and get one approved.
Well, thank you, everybody. Please thank our amazing doctors who spent their time. Yeah. And we will head back out to the end of there's one more presentation for everybody where they'll give talks about projects. I'm giving one, so if you want to stay and see mine. And then we will have a moment to meet, and then we'll go to dinner at 7:30. Please feel free to join at 7:30. We are going to Biamba will have to say it for me because desperately trying to understand Italian is not my strong suit. It's behind here, but you'll hear it again before. Thank you, everybody.